So we'll say I was dispatched to a chest pain, okay? The first thing I'm gonna do, just real quick, if I'm talking to my patient, I will be facing him, talking to him, and having a conversation. If I'm talking directly to you guys, it's as if I'm talking to my proctor, okay? All right, so BSI, scene safety, so I have my personal partner, patient safety. I don't see any environmental hazards right now. I have one patient. The nature of illness I was dispatched to was a chest pain. We're gonna go ahead and start ALS right now, and need for C-spine or extrication, probably not. I'm gonna go ahead and approach my patient, walk into the door. My general impression, adult male sitting upright in a chair, who appears to be in no distress. I don't see any immediate life threats at this point in time, okay? Hey, sorry, my name's Raj. I'm with the ambulance. What's going on today?
No, I just have a lot of chest pain today.
Okay, what's your name?
Jimmy.
Where are you right now?
I'm at UCLA Medical Center.
Okay, do you know the day of the week?
It's Sunday.
Okay, all right. So it's as if we just hit pause on Netflix right now, all right? So my patient is alert and oriented ×4. His airway's patent. There's no need for suctioning, no need for adjuncts. The breathing I assessed while I was talking to him just now. The rate is normal, the rhythm is regular. The quality is unlabored and tidal volume is adequate, so there's no need for O2 and there's no need for lung sounds. Circulation, I palpated his pulse as I was talking to him. The rate is normal, rhythm is regular, quality is strong, and his skin signs were pink, warm, and dry, or normal, warm, and dry. I don't see any obvious bleeding. This patient has no physical deformities. He's alert and oriented ×4. There's no neurodeficit. There's no need to expose. The chief complaint he told me already was chest pain and transport decision. I'm going to go ahead and ask my proctor how far ALS is, how far the hospital is.
15 minutes hospital, 20 minutes ALS.
Okay, we're going to go ahead and transport this patient to the hospital. All right, so we'll get him on the gurney, get him in the back, and then we'll start rolling the hospital. I'm going to go ahead and continue my assessment. Get my partner to take a full set of vitals, so that's blood pressure, eyes, lung sounds, level of consciousness, skin signs, respirations, pulse, and pulse ox. And then I'm going to go ahead with my history and ask the patient. All right, what were you doing when your chest pain started?
I was walking uphill.
You were walking uphill? Okay, how long ago was that?
That happened about 20 minutes ago.
Okay, did it come on, your pain, did it come on sudden, all of a sudden, or did it build up over a period of time?
No, it started to build up.
Built up over that 20 minutes?
Exactly.
Okay, anything make it better or worse?
When I sit down, I feel a little better.
Okay, how would you describe the pain in a few words?
Just feels like pounding.
Like pounding?
Pounding
Okay,
sensation.
so like a throbbing in your chest?
Yes.
Okay. Can you point to where that pounding is the worst with one finger? Right there in the middle? Does it move anywhere from there?
No.
No? Have you ever felt anything like this before?
Never.
All right. On a scale of 0 to 10, if 0 is no pain and 10 is the worst pain you've ever had, what number would you give it?
I'll say about 9.
9? Okay, and he says we can go on for 20 minutes.
Yes, correct.
All right. So signs and symptoms right now is substernal throbbing pain that's non-radiating for approximately 20 minutes. That gets better when the patient sits down or ceases activity. He said he was walking uphill when it started. Do you have any allergies?
Yes, to a penicillin.
Penicillin? Okay. Do you take any medications currently?
No, I don't.
All right. Do you have any medical problems?
I have asthma.
You have asthma? Okay. You don't take any meds for asthma?
Not at
No
the moment.
inhalers or anything?
No.
Okay. Last ins and outs would be an inappropriate question for this since the patient's complaining of chest pain. All right. At this point, I'm done with the history. I'm going to go ahead and perform a focused physical exam of the patient's chest. So I'm looking for paradoxical movement, sucking chest wounds, accessory muscle use, subcutaneous emphysema. I'm going to go ahead and palpate for sternal stability, the clavicles, and the chest. Take a deep breath. All right. I'm going to go ahead and take a full set of lung sounds in all 6 fields on the front and on the back. My proctor will give me the vitals when I'm ready for them, and at this point I'm done with the assessment. I'd reassess every 5 minutes and give a transfer of care report to the hospital when I get there. All right, so that's it. So